Go ahead, Vishal. Go ahead.
Very good evening, sir. Ma'am, Dr. Naina, ma'am, please go ahead, ma'am.
Yes. Deepa, madam.
Yeah. Good evening, everybody. And this is the first webinar from Mumbai after we have, with the inception of the new team for RSACP Mumbai. I welcome patron Dr. Tejkal sir, ex-president Dr. Indrani Hemant Kumar, President Dr. Naveen Malhotra, President-elect Dr. Anju Grewal, and Secretary Dr. Vishal Singla. I thank you all for giving us this platform, and we hope to live up to the RSACP academics. I hand over the mic to Dr. Naina Darvi to continue with the proceedings.
Thank you, madam. To start with the webinar, I would first like to request our patron, Dr. Tejkal sir, to say a few words.
No. Hello. Is it okay now? Am I audible?
Yes, sir. Yes,
Yes.
sir. Very much.
A very good evening to the family of RSACP. Great beginning under the dynamic leadership of Dr. Naveen and Dr. Vishal. It is a great event to have started this webinar again with recent trends in regional anesthesia. Good going. Keep the tempo on. Don't be laxing in any way. I am sure all of you have the brilliance, ability, and the agility to take RSACP to great heights. Please continue your efforts. Best wishes to the organizers. Thank you very much.
Thank you, sir.
Thank you very much. Thank you, sir. Thank you for your blessings, sir. And we hope to continue the good work started by you all. And now I request RSACP President Dr. Naveen Malhotra to address the gathering.
Good evening, all. Respected Dr. Tejkal sir, office bearers of RSACP National and RSACP Mumbai. Heartiest congratulations to team RSACP Mumbai, led by Dr. Deepa Kane, with able support of Dr. Devangi and Dr. Naina, and under the able guidance of Professor Indrani Hemant Kumar. I'm very pleased that we're kickstarting the RSACP Academic Webinar Series 2024. Soon we will be launching going into 2025. And as a part of 40 years celebration, this is an important milestone in the history of RSACP. Numerous events are lined up in the coming week also and in the new year also. So best wishes to all of you, and thank you, Vishal, for organizing this webinar. And best wishes to all speakers. I am very sure it will be a nice academic feast for all the delegates. Thank you very much.
Thank you very much, Naveen Malhotra, sir. And I'm sure you all will definitely have a good academic feast for another 1.5 hours. And now let's start with our today's webinar on regional anesthesia update. At the beginning, let me introduce both the moderators for this webinar. We have our first moderator, Dr. Deepa Kane, madam. Madam is a professor in Department of Anesthesiology at St. G.S. Medical College and KEM Hospital, Mumbai. She is currently the president of RSACP Mumbai. She is also the coordinator of Regional Anesthesia Fellowship Program of MUHS. Welcome, madam. And our second moderator for the session is Dr. Sona Dave. Sona Dave, madam, is professor at TN Medical College and Nair Hospital, Mumbai. She is also a coordinator of Regional Anesthesia Fellowship Program of MUHS. So I welcome both the moderators. And then let's start with the webinar. Our first speaker today happens to be again Dr. Deepa Kane madam, and she will be discussing with us a paper on international consensus on anatomical structures to identify on ultrasound for the performance of basic blocks in USG regional anesthesia from RAPM 2022. Welcome, madam.
Thank you, Naina, for your kind words. And I bring you greetings from St. GS Medical College and KEM Hospital. And I'll be speaking on the international consensus on the anatomical structures to identify on ultrasound for performance of blocks in ultrasound-guided regional anesthesia. I thought it important to talk on this paper because we all know about difficult airway guidelines and so many guidelines. And now there has been an international consensus on what anatomical structures one should see before we give, especially the Plan A blocks. It's not moving forward. Okay, so I'm going to speak on this consensus of anatomical structures one should see with ultrasound for the ultrasound-guided nerve blocks. Now, the aim of this study was to generate a consensus on the series of anatomical structures one should see on ultrasound for performance of Plan A blocks under ultrasound guidance. Ultrasound-guided regional anesthesia is not new. Ultrasound was used for regional as early as 1989, and image interpretation, looking at anatomical structures happened long time back. But there was lack of consistency in the anatomical descriptions and what anatomical structure should be seen before each block. And there was no universal agreement to what structures should be seen. So now there is a consensus on this topic. So there are 7 Plan A blocks which are discussed, and they are the interscalene, the axillary level brachial plexus block, the rectus sheath block, the erector spinae block at the thoracic level, the femoral nerve block, the adductor canal block, and the popliteal level sciatic nerve block. So Plan A blocks are high-value blocks. They were first described by Turbit and his colleagues, and then they were endorsed by the regional anesthetists of UK. Coming to the first Plan A block, that is the interscalene level brachial plexus block. The second one is the axillary level brachial plexus block. Next is the erector spinae plane block at the thoracic level. Next is the rectus sheath plane block at the abdomen. Next, in the lower limb, you have the femoral nerve block, the adductor canal block, and the popliteal level sciatic nerve block. So we have 7 Plan A blocks. So this study was conducted by the regional anesthetists of UK, and it was endorsed by the American Society of Regional Anesthesia and Pain Medicine and the European Society of Regional Anesthesia and Pain Medicine. When you scan with the probe to get the view, there are 2 components or 2 phases of the scanning. One is the dynamic scanning to get the view, and that they called the orientation scanning. And the final view, what you got just before you put in the drug, that was called the block view. So they had a Delphi technique, and there were 27 UK-based key opinion leaders. So for Delphi technique, they take intellectuals with expert opinions, and based on their opinions, they come to certain conclusions. And they used a 4-point Likert scale. Like for every block, they had structures pointed out, whether it's the muscle, the bone, the artery, the vein. And against every anatomical structure, every expert would write whether it is definitely to be included, probably to be included, probably excluded, or definitely excluded. So if more than 75 experts called a structure as to be definitely included, it would go further and it would not
Godam,
the second round. Whereas if more than 50% of the experts said it's probably to be included, then it went into the next round. So they had a 1 round, a second round, and a third round. And at the end of it, they came to very strong recommendations and weak recommendations about which anatomical structure should be seen for each of the plan A blocks. So for the interscalene level brachial plexus block, now for everything there will be two, one is the orientation scanning and one is the block view. So for the orientation scanning, which is the dynamic scanning, one has to look for the anterior scalene, the middle scalene, the C5, the C6, and the upper trunk of brachial plexus. But once you come to the final view, you have to see for anterior scalene, the middle scalene, the C5, C6 nerve root. That's it. And all other things which we see, like the common carotid, internal jugular, they are all weak recommendations. We don't have to see them. When it comes to the axillary level brachial plexus block, it is the same actually for dynamic and the final block view. We have to see the axillary artery, the axillary veins, the conjoint tendon, the nerves, that's the median nerve, the ulnar nerve, the radial nerve, and the musculocutaneous nerve. The others like the humerus, the biceps, the coracobrachialis, which we see otherwise, they all come under weak recommendations. If you look at the thoracic level erector spinae plane block, when we're doing the scanning, we start with the ribs. So we will be seeing the ribs and the erector spinae muscles and the transverse process and also the pleura when we're doing the orientation scanning. But when we do the final block, all that we have to see is the transverse process and the erector spinae muscles. For the rectus sheath block, when you're scanning, we see the rectus abdominis, the anterior, the posterior rectus sheath, the linea alba, the peritoneum. And for the final scan, we will see the rectus abdominis, the anterior sheath, the posterior sheath, and the peritoneum. There's no need to see the linea alba. In the femoral nerve block, for the orientation scanning, we see the femoral artery, the vein, artery, nerve, the iliopsoas, the fascia iliaca. But in the final scanning, final block view, we just have to see the femoral artery, the nerve, the iliopsoas, the femoral nerve, and the fascia iliaca. We need not see the femoral vein because femoral vein becomes the weak recommendation. For adductor canal, for orientation scanning, we see the femoral artery, the sartorius, the vastus, and the saphenous nerve and the nerve complex. But for the final block, we need not look at the vastus. We have to see the sartorius, the femoral artery, the saphenous nerve for the final view. For the popliteal sciatic nerve block, for the orientation scanning, we have to see the popliteal artery, the sciatic nerve, and then the bifurcation into the tibial and the common peroneal. And for the block view, we just need to see the nerve where it is diverging and the tibial and the common peroneal. So in conclusion, just by the Delphi process, they came to certain conclusions or strong or weak recommendations for ultrasound scanning for 7 plan A blocks. And this information is intended to support consistent practice, and they need to empower the non-expert to facilitate approach of using a small number of high-value nerve blocks. Now, the idea of a small number of high-value nerve blocks is because of the multimodal analgesia that all are expected to use. So they want to standardize the minimum set of structures so that more number of anesthetists can use it in their daily practice. And this may also aid in improved and consistent communication, teaching, and research in the field. Thank you. Hello.
Thank you, Dr. Deepa.
Yeah, thanks, Sona.
Yeah. So are these guidelines given somewhere, or meaning which this thing, these 7 plan A blocks, like
So this is a paper which I just read from RAPM, the
huh.
Regional Anesthesia and Pain Medicine 2022. I just wanted to make everybody aware, the same way as we have the difficulty away guidelines and other guidelines, people have started thinking about international consensus on what structures one should be seeing. And the idea of Plan A blocks is that more and more people find it very familiar to use these blocks, and they can be easily used.
So you can just define plan A and plan B blocks, meaning
So there are
exactly.
7 blocks which are called the Plan A blocks. I mentioned to them in the upper limb, the scalene above shoulder, the axillary at the brachial plexus below the shoulder, then the erectus spinae at the thoracic level, rectus abdominis at the abdomen level, and the lower limb we have the femoral, the adductor, and the popliteal sciatic. So these
Yeah,
are the Plan A blocks. These are the blocks which are like commonly used, which should be commonly used. And the structures are, it's very clear which are the structures one should see, and they can be used for day-to-day practice. The idea is like more and more people should be using this regional anesthesia techniques. It's not only for the regional anesthetists. So the more advanced types of blocks or the newer blocks, maybe all the regional enthusiasts can work on them. But these basic things are for all the general anesthetists.
but then plan B, see what does actually plan B mean? If plan A fails, then plan B. That is so what is then plan B blocks exactly?
So they've included all other blocks under Plan B, C, D. They call them Plan B, C, D.
Oh.
You want to say something else? You want to comment something? You may comment.
Yes, that's what I wanted to clarify. Can go to the next speaker now.
Yeah.
I need to be allowed to share my screen.
So Naina, can you introduce Dr. Devangi?
Yes. Yeah. So thank you, madam. Thank you, Deepa, madam,
you.
for this, beautiful introduction.
Dr.
and
Devangi, you have been
just-
made the co-host. You may please share your screen.
Thank you.
So our next speaker for today's webinar is Dr. Devangi Parikh, and she will be talking about what's new in regional anesthesia blocks. Dr. Devangi is working as an additional professor at Lokmanya Tilak Municipal Medical College and LTMGH Hospital, Mumbai, and she is the mentor for Regional Anesthesia Fellowship of MUHS. Over to Devangi.
Yeah, thank you very much. I thank RSACP and RSACP Mumbai President, Dr. Deepa Kane, Madam, for giving me this opportunity, and I hope I do justice to the lecture. So with that, we start. So what's new in regional anesthesia blocks? So I'll be discussing the newer blocks starting from 2019 to 2024. There are not many, but the ones which have stood the test of time is the abdominal wall blocks, that is the M-TAPA, and the external intercostal plane block, and the lower limb blocks, that is the parasacral ischial plane block, and the CAPS block, that is the popliteal sciatic level nerve block in the supine position. So starting with the abdominal wall blocks, so all of us are giving regional anesthesia for upper abdominal surgeries. So quick revision of the journey so far. All of us are mostly giving the oblique subcostal tab block, either medial or lateral to the lead linea seminularis, but it is giving a coverage of mostly the T6 to T9 level. Then we have the erectus spinae, which has to be given posteriorly, or even the transmuscular quadratus lumborum, which has to be given in the flank. Now the problem, these two are good blocks with extensive coverage than the oblique subcostal, but it requires that the patient has to be turned to the lateral or the prone position, and that is a little cumbersome. A quick revision of the abdominal muscle attachment. So the outermost muscle is the external oblique, which has an external attachment on the 5th to the 12th ribs. If we retract the external oblique in the thoracic cavity, immediately the intercostal muscles appear, and in the abdominal cavity, it is the internal oblique. Now, this internal oblique is attaching on the inner surface of the lower 4 ribs. Posterior to the internal oblique is the transversus abdominis, and it has an attachment on the inner surface of the costal margin. The T7, T8, T9, T10, and T11 are the thoraco-abdominal nerves, which are mainly supplying the upper part of the abdomen. So with this quick revision, the main block that I wanted to discuss is the TAPA and the M-TAPA block. That is the thoraco-abdominal nerve block through the perichondrial approach. So this has been described by Tulgar et al. In 2019. A linear transducer is placed on the costochondral angle in the parasagittal plane between the mid-axillary and the anterior axillary line, and angle deeply to view the lower aspect of the chondrium. So we are basically looking at the costal cartilage, the lower aspect. The logic behind it is the 6th to the 10th intercostal nerves pass under the quadrion between the origin of the transversus abdominis muscle and the costal cartilage. So here, the problem is only the probe position. It's a slightly tricky. We may just get a good view with this position, or sometimes we have to angle it this deeply. So needle insertion in this position can be in-plane technique like the way it is depicted here. But with this technique, it's impossible to introduce the needle. Basically, the needle has to go from the caudal to the cranial direction. So it is impossible to introduce the needle. So here we'll have to go a little out of plane. So this is a main challenge, or rather technical challenge, in this M-TAPA block. Now, Tulgar et al. Initially described a 2-injection technique, one superficial to the costal cartilage and one deep. Now, the modified M-TAPA is in use, and that only describes one injection, that is between the origin of the costal cartilage and the transversus abdominis muscle. So it's exactly here. And this is where your local anesthetic is deposited, around 20 to 30 ml as per Tulgar's description. Now, coming to the clinical applications of M-TAPA block. So there have been 2 randomized control trials so far, where M-TAPA was compared to no block in the control group. And obviously the results was that M-TAPA gave a good analgesia at rest as well as movement, as well as a better quality of recovery score. However, when M-TAPA was compared with subcostal tap, our own old subcostal tap in laparoscopic cholecystectomy, the researchers found no difference in the pain scores at movement or rest, or even the pain intensity. So what exactly does M-TAPA block cover? When Tulgar et al., when he reported this block initially in 2019, he reported an extensive coverage from the xiphisternum till the infraumbilical area up to the lateral abdominal wall. However, a recent study published in RAPM 2023, it was a cadaveric study by Savada et al., and he depicted that it's only the anterior cutaneous branch of T9, T10, and T11 which are consistently blocked, and it is very, very similar to injection in the subcostal tap plane. Another volunteer study was done in 2022, and they also concluded the same thing, that it is mainly the anterior cutaneous nerves which are getting covered. And this study of evaluation of sensory loss was done in patients undergoing gynec laparoscopic surgery. This was another very good paper by Aikawa et al. And bilateral M-TAPA block was performed, and they also reported that, see, in the anterior area, T8, T9, T10 was consistently blocked. In the lateral, it was in 50 to 70% of the patient, and T6, T7, only 40% of the patients were covered, and even lesser in the lateral area. So what will be the indications of M-TAPA? Well, it's quite a limited block, so it's mainly for supraumbilical surgeries with midline incisions, and the block effect depends a lot on the volume used. Larger volume, better coverage, surgical position like a head-low position in gynec laparoscopy, better coverage, and a craniocaudal spread. Overall, it has a very limited profile, and there are mixed results. Coming to the next block, that is the external oblique intercostal plane block. So this has been described by Hamilton et al. In 2019 in a cadaver. So he basically placed a high-frequency linear transducer in the mid-clavicular line at the level of Zippy sternum. So basically, we can go in line with the Zippy sternum, or we can go from the sternal angle and come down, counting the ribs. After placing it in this position, you obliquely rotate it such that the caudal end points towards the anterior axillary line. And at that point, the injection is started between the external oblique muscle and the intercostal muscle. So here the external oblique and here is the intercostal. Here the drug is injected, and we can move the probe towards the 8th intercostal space and continue depositing a drug for a better coverage. This was a cadaveric study. So Hamilton et al., they dissected the cadaver after all these injections, and they saw that the anterior and the lateral cutaneous branches from T6 to T11 all were stained. So I'd like to bring you all to the rough anatomy of an intercostal nerve. The intercostal nerve, after being given off at the angle of the rib, it gives an ascending trunk which gives off the lateral cutaneous branch. So when Hamilton et al., when they injected obliquely from the 6th rib, he was mainly targeting this ascending trunk, which led to the spread to the lateral cutaneous. And that's why it's quite a promising block. This was confirmed by White et al. In 2022 for an extensive coverage in this area. RSACP et al. Also did another clinical study. Like Hamilton had done a cadaveric study, he did a cadaveric as well as a clinical study where the block was performed for post-operative pain control after open abdominal procedures involving the upper lateral quadrant incisions. 22 patients he has given the block, out of which 16 patients received a bilateral injections and 6 patients even received a continuous catheter. And it sounded to be a very promising venture. So he also did a cadaveric study, and he also confirmed the findings that the anterior as well as the lateral cutaneous branches both are getting blocked in this. So what are the clinical applications of EOI plain block? Because it's a very recent block, there are mainly case reports, case series, small isolated cases, and one RCT. The surgeries which are included is a sleeve gastrectomy, open nephrectomy, liver surgeries, morbidly obese patients where they placed a catheter, and it has very positive findings in terms of better pain control and lower opioid consumption. So let us compare the subcostal tap versus M-TAPA versus the EOI. So subcostal tap, whether we inject lateral or medial to the linea seminidaris, the coverage of the anterior cutaneous nerves will happen. Whereas the lateral cutaneous nerves, again, is plus minus. We are not too sure. Depends again on the volume. What about M-TAPA? Yes, the studies have shown that the anterior cutaneous nerves T8 to T10 are certainly blocked. Again, not too sure about the lateral cutaneous nerves. An external oblique plain block, the anterior and the lateral both get blocked from T7 to T11. So what are the plus points of the EOI block? The EOI block represents a very important modification that may consistently cover the upper lateral abdominal wall. It has easily identifiable sonographic landmarks and can be performed with the patient in the supine position. Now, this is very important in contrary to QL or ESP. It has needle catheter insertion sites that are more distant from the site of surgery. So we can even institute this block post-operatively. And it is amenable to catheter insertion even in obese patients. The limitation is that like other blocks, it lacks visceral analgesia coverage like the TAP, and also it does not reliably extend below the umbilicus. So with that, I come to the lower limb blocks. So I'll be discussing two. One is the parasacral ischial plain block, which is a foreign author, and this is our popliteal sciatic block in supine position, which is by our Indian researchers from the Ganga Medical Center, Coimbatore. So before I start both the blocks, let me cover the anatomy of the sacral plexus. So sacral plexus is from the ventral rami of L4, L5, S1, S2, S3. And then the sacral plexus goes through the greater sciatic foramen. The posterior view is closely related to the posterior border of the ischium. This is the sacral plexus related to the posterior border of the ischium. And it is covered by the piriformis muscle, which is further covered by the gluteus maximus muscle. So before I tell you all the parasacral approach, parasacral ischial plane approach, I must revise the old tried and tested, the Benston's parasacral parallel shift approach. The reason I discuss this is the PIP block, the new block, relies on this method itself. So Benston et al. In 2011, he devised this method to block the sacral plexus. So in this method, the line is drawn between the posterior superior iliac spine and the greater trochanter. Midpoint of the line is drawn. A curvilinear probe is placed on the medial half of the line. At that time, what we see is a continuous hyperechoic structure, which is the ala of the ilium. After that, the probe is moved caudally, parallelly, inferomedially, to find a break in this ala of ilium. The moment we find a break, it is usually the sacral plexus. So Benston et al. Inserted the needle over here to block the sacral plexus, and it can be USG plus PNS guided. In the PIP block, we are not injecting over here. We are mainly injecting at the posterior border of the ischium. So what is the logic of this block? Coming to the parasacral ischial plane block, it is the same thing, PSIS to GT. Okay, so here what happens is, we are again going to see the ala of ilium. We move the probe like the Benston's parallel parasacral parashift approach. And here we localize the same thing what Benston has watched, the ischium, the sacrum, and the sacral plexus. So the logic behind this block is that the piriformis muscle, it is covering the greater sciatic foramen, and directly it is attaching to the greater trochanter. There is absolutely no bony attachment on the ischium. So there is a facial plane which is existing between the undersurface of the piriformis muscle and the bony part of the ischium. And this is what Madan Narayan and group have tackled by depositing the drug at the ischium such that it spreads medially towards the sacral plexus. It's an indirect way of plague blocking the sacral plexus. The cadaveric validation was also done by the same group, Madan Narayan et al., and they confirmed that the dye is noted around the sacral plexus, including the sciatic nerve and the posterior cutaneous nerve of the thigh. What about the clinical evaluation? This block has one case series has been reported in Indian Journal of Anesthesia in 10 cases for lower limb debridement as a primary anesthetic block along with the femoral or the adductor canal. And what the researchers found is that there was complete sensory blockade up from 15 to 18th minute. However, they did not find a complete motor block at 30 minutes. Patient was moving the ankle, patient was moving the toes, but there was no pain on debridement. So surgeons were a little uncomfortable, but otherwise the case could be completed without any analgesics. So what are the plus points of the PIP block? Numerous ultrasound-guided approaches have been described for the sacral plexus. However, all of them identify the plexus either with ultrasound or nerve stimulation. And sometimes we may just lose the plexus in obese patients. Sometimes we may go very deep if the needle is not seen and we may enter the pelvic cavity, or the pudendal nerve also can get blocked. PIP block relies on bony ultrasound landmarks which are easily identifiable, and the desired endpoint is a simple facial plane spread. The needle stays well away from the neurovascular structure, especially the inferior gluteal vessels, and thereby increasing the safety. Coming to the next block, the ultrasound-guided popliteal sciatic nerve block. As Deepa Kane madam said, it's a plan A block. Conventionally, this block is done in the lateral or the prone position, and we are targeting at the level of divergence into tibial and common peroneal. But only thing is a little cumbersome if the patient has an external fixator, if he is severely traumatized, a very bad wound, then turning to lateral or prone becomes very difficult, and everyone wants a supine approach. So this is a review of literature where multiple supine approaches have been tried from 2004 to 2016. So here we are seeing that the probe is placed posteriorly, injection is also happening posteriorly. Here also the probe is placed posteriorly and injection is happening from the lateral part of the thigh. Here Taha et al. Has injected from the medial part of the thigh, and this is a gap supine position. Again, the probe will be placed posteriorly. But if you notice all these pictures, all these positions require either a hip or a knee flexion or some assistance to lift the leg. So we have our Indian researchers, Dr. Tyuhin Mistry and Karthik Sonavane et al. From Ganga Medical, who have told us that there can be a popliteal block from the supine position without any limb manipulation. So this block basically is a crosswise where you're placing the probe on the lateral part of the thigh such that the USG beam is perpendicular to the sciatic nerve. And this generates a transverse cross-section image where you have the femur laterally, anteriorly, vastus lateralis over here, biceps femoris, And medial to the biceps femoris is the sciatic nerve. It is visualizing the sciatic nerve in the short axis, and the popliteal vessels may or may not be seen. So here, what you do, you take a linear or a curvilinear probe. Now in this picture, I have used a linear probe because it was a thin-built patient. And in this picture, I have used a curvilinear probe. So you use a linear or a curvilinear and you go 5 to 10 centimeter proximal to the popliteal crease at the point of divergence or where you see the whole sciatic nerve. You position the probe between the vastus lateralis and the biceps. This groove is, you can't miss the groove. You position the probe over here. If required, you may put a towel so that you can create the room for probe placement. Otherwise, this supine position is also enough. After that, we have to inject near the sciatic nerve. Out of plane, in my experience, has been better than in plane because in plane, you tend to overshoot the nerve. So out of plane terms better, and you see for a local anesthesia spread around. Volume is around 20 to 25 ml. A clinical evaluation, the same group did a clinical evaluation in 5 random patients. They just wanted to see the feasibility. So they gave it as a post-operative recovery block after the anesthesia effect of spinal epidural worn off. And the main aim was feasibility. So they saw that there was no assistance required for positioning the patients. And even I endorse this because I've given many blocks like this and really no assistance is required. And the duration of analgesia was 16 to 18 hours. So what are the plus points? It's a simple and convenient position for both patient and anesthesiologist, does not require assistance. Combining caps with femoral or saphenous nerve block can provide complete analgesia for below the knee joint surgeries. So to summarize, these are the latest regional anesthesia block within the last 5 years added to the armamentarium. EOI plain block seems to be a simpler and more feasible option among the current available blocks for upper abdominal surgery. Similarly, the PIP and the CAPS block seem to be easier and more practical than their existing counterparts. PIP seems to be more of an analgesic than an anesthetic block, but it needs further studies to confirm all the new findings of all these new blocks. This is my hospital, the LTMMC Sion Hospital. Thank you very much.
Thank you, Dr. Devangi. Any further tips for this caps block and what is the volume you're given? Because
so for the caps block, 20 ml is sufficient. One tip I would like to give is that it's better to go USG plus PNS. So basically, we are approaching this nerve from the lateral thing. So it's the fibular component mainly which comes. So like that, the researchers have said dorsiflexion or plantar flexion, either way is okay. But I would prefer a plantar flexion response for the tibial component. So Anat, sometimes what happens, we can't see the fibula and the tibial components separately. So something which we see as a sciatic nerve may just be the fibular component or may just be the tibial component. So it is better to go USG plus PNS. This would be my tip.
is that groove important? Meaning
it's a very important thing because we position the probe between that groove. So on the femur, we see the vastus lateralis, and then we should have all our focus on the biceps femoris because the nerve is immediately medial to the biceps femoris. So then we can ignore the vastus lateralis. We should be able to find the borders of biceps femoris and the nerve medial to it. Popliteal vessels may or may not be seen. If it's a very thick thigh, obese thigh, we may not see the popliteal vessels.
And what is the depth you get it at nearly?
Roughly 6 to 8 centimeters.
Can we go to the next speaker now? Next speaker for today is Dr. Viral Parikh. He's the consultant and he's the consultant anesthesiologist at PD Hinduja Hospital, Khar. And he has one more feather in his cap just now. He is inducted as an educational board member by the NYSORA. Congratulations, Viral. And he is also a member in ISA Mumbai Metro branch. Over to Viral.
Thank you, ma'am. I'm audible, right?
Yeah.
So, good evening, everyone. So, at the outset, I would like to thank Dr. Naveen Malhotra sir, Dr. Singla sir, and Dr. Deepa Kani madam for giving me this opportunity. My talk today is on peripheral nerve injury in regional anesthesia. So, the outline of my talk, I'll be describing what is known as the PDND, the factors causing peripheral nerve injury and the mechanisms, how to mitigate peripheral nerve injury, the diagnosis and management in short. So, this article about nerve injury following regional nerve block states that all peripheral post-surgical or post-anesthesia related injuries are being described as a post-operative neurological symptoms or post-block neurological dysfunction. So what is it? It's a spectrum of abnormal nerve function which extends past the typical duration of anticipated neuronal blockade. And so whenever we give any single shot peripheral nerve block, the time to recovery which we accept is within 48 hours, both the sensory as well as the return of motor function. However, any abnormal extension of motor weakness or altered sensorium prolonging more than 48 hours along the distribution of neuronal block is being described as a post-block neuronal dysfunction or perioperative neurological symptoms. So what is the incidence of perioperative peripheral nerve injuries? This article from 2009 evaluated 380,000 cases, and they identified new sensory or motor deficit, and they excluded the injuries as a result of surgical procedure, and the incidence was around 0.02%. However, what was their finding was that they were associated with hypertension and smoking, but not the peripheral nerve blocks. Similarly, this article in RAPM states that the incidence and etiology of postoperative neurological symptoms, they evaluated 26,000 peripheral nerve blocks in 19,000 patients. And the incidence was around 0.02%. The prolonged neurological symptoms, more than 10 days, which were related to the regional anesthesia. And it was like 2 in 10,000 patients. So many more studies suggest the similar incidences. And it states that the risk of postoperative nerve dysfunction is rare. However, how true is it? It might not be true because of the lack of documentation or underreporting, because of the fear of the medical legal aspects, or there could be improper follow-up. So let us describe the anatomy of a peripheral nerve. The smallest unit of a nerve is the nerve fiber, which is the axon. It could be a myelinated or an unmyelinated nerve fiber, which is surrounding by the Schwann cells. The connective tissue surrounding the nerve fiber is the endoneurium. Multiple nerve fibers unite and join to form fascicles, which are surrounded by the perineurium, which is the toughest connective tissue, which prevents most of the neurological injuries. Multiple fascicles, they unite together and form a nerve, peripheral nerve, which is further surrounded by the epineurium. And in this cross section, we can see the sciatic nerve, which is divided into tibial and common peroneal component. And it has an extra connective tissue sheath which is surrounding them, which is termed as the paraneurium. So what are the risk factors for perioperative nerve injury? It could be pre-existing diseases. There could be patient-related, surgery-related, perioperative conditions, or due to anesthesia-related factors. So the risk factors, in patient-related, it is more in male gender. Patients who are high smoker with pre-existing neuropathies, advanced age, extremes of body habitus. Surgical related, it could be because of the surgical trauma or stretch, tunicate ischemia, vascular compromise, perioperative inflammation or infection, hematoma, fast compression or irritation, and patient positioning. Anesthesia related, which we are mostly related, is that could be because of the paresthesia or pain on injection during administration of local anesthetic, or it could be because of the needle or catheter induced mechanical trauma, ischemic injury, vasoconstriction, perineural edema, or because of the direct effect of the local anesthetic or adjuvants. And perioperative condition related because of the untreated hypovolemia, dehydration, hypotension, hypoxia, and so on. Coming to the mechanisms, as I described, the mechanical factors because of the compression and entrapment, stretch and laceration, traumatic because of the needle or high injection pressure. Chemical causes is because of the local anesthetic or adjuvants. Ischemic factors, it could be because of the vascular injury, because of the injury to the intraneural as well as the extraneural vascular structures, or because of the prolonged pressure ischemia or global hypotension, positioning, and tourniquets. And there is another component which is known as the inflammation of the nerve. So what are the various types of nerve injuries? So the Sidon and Sunderland have classified it. So in Sidon classification, they have divided it into neuropraxia, axonotmesis, and neurotmesis. So Sunderland further classified axonotmesis into three further divisions as like mild, moderate, and severe. So in neuropraxia, there is only focal demyelination with intact axon. I think something has changed. Yeah. So in neuropraxia, it is mainly because of the focal demyelination with intact axon, uh, leading to slow conduction. However, the prognosis is good. In axonotmesis, depending upon the involvement of endoneurium, perineurium, and epineurium, it is further classified, and the prognosis is fair. However, in neurotmesis, the whole of the nerve is severe, and the prognosis is poor unless and until there is surgical repair, which is done immediately. So let us describe the mechanical factors. The most important factor which we are concerned is the type of needle and the needle bevel angle. So there are multiple needles which we have available in the market with the different bevel angle. It could be a pointed short, a long bevel needle with a 15-degree, or a short bevel, or a blunt needle. So what is the incidence or injury which can happen with a sharp tip needle? It penetrates the nerve more and deeper. It produces cleaner and more likely to heal cuts. However, with the injury produced by sharp tip or long bevel needle, the recovery is faster and more complete. It is more likely to enter the fascicles but causes less extensive damage. However, the blunt or short bevel needle, the nerve penetration chances are low and less deep. However, it produces non-congruent cuts and causes more extensive damage. The recovery is slower and incomplete. Now, the next component is the site of injection. Where should we inject our local anesthetic? So in this picture, we can see there are three positions. In position A, the needle is extraneural and extrafascicular injection. The needle has not punctured the epineurium, so it is considered to be the safe. However, if the needle enters the or punctures the epineurium and enters into the intraneural but the extrafascicular compartment, still the chances of nerve injury is less. The most disastrous nerve injuries happens at point C, where the needle has entered the intraneural and the intrafascicular compartment. Now coming to the intraneural injection, the damage further depends upon the neural as well as the non-neural ratio of that particular nerve. So in this picture A, we can see that the needle has entered the intraneural, but it is extrafascicular, because in this type of nerve, the connective tissue is more compared to the neural tissue. So the risk of nerve injury is still less. However, if the needle is intraneural with intrafascicular needle tip, this could be with the possibility in nerves which have a lower connective tissue with higher neural tissue, and there is the chances of more damage. So as we know that in the brachial plexus, the more proximal approaches to the brachial plexus, like the interscalene or supraclavicular area, there is less amount of connective tissue and more neural tissue. So there is more chances of nerve damage compared to the distal approaches. The second is the angle of needle approaching towards the peripheral nerve. So we can either approach direct, or we can approach in a tangential pathway to the particular nerve. So this article, which was a cadaveric study about the ultrasound guided approach to nerves, they demonstrated that when the needle approaches nerve in a tangential direction, with gradual insertion of the needle, the nerve starts rotating because of the surrounding connective tissue, and there is no neural puncture. And these are the ultrasound images of the ulnar nerve at the arm. So we can see that when the needle is approaching directly towards the nerve and the injection is done, there is increase in the cross-sectional area of the nerve. Coming to the pressure injury, all of us are aware of the injection pressure. So whenever an injection is done around the nerve, if the needle is placed inside the perineurium with a high injection pressure, it can lead to perineurial rupture, and which leads to loss of protective layer around the axon and can lead to axonal injury. So if the intrafascicular pressure is more than the capillary perfusion pressure, it can lead to neural ischemia and inflammation. Coming to the neurotoxic injury because of the local anesthetic, most of the commercially available local anesthetic are safe clinically at available concentration, and the chances of neurotoxic injury is rare. However, it is dose dependent. So if the dose is high as compared to what is desired, or if the duration of exposure of the nerves to the local anesthetic is more, the chances of neurotoxic injury increases. Now coming to the ischemic component, the severity is proportional to the duration of interruption of the blood flow. There are various mechanisms like the tourniquet because of the direct needle injury or because of the hematoma. So as we can see that if the ischemia time is less than 2 hours in the tourniquet, when the tourniquet is applied, the nerve function can return to normal within 6 hours. However, if the ischemia time is more than 6 hours, the time to return to nerve function is prolonged. A word or two about the double crush syndrome. As we know that if any patient has a peripheral nerve injury preoperatively, we try to avoid nerve blocks. So what is it? Double crush syndrome. So it was first proposed by Upton and McComas in 1973. And they stated that the peripheral nerve, which is compressed proximally, is more susceptible to a distal compressive lesion than a nerve that has not sustained a proximal compression. It was primarily described in context with simultaneous occurrence of cervical radiculopathy and carpal tunnel syndrome. However, the exact mechanism is still not definitively understood. It could be because of the disturbances in the axonal flow of nutrients or because of the disruption of the architecture of neurofilaments. There is another term which is called as the post-surgical inflammatory neuropathy. So when the common causes of the injury like traction, compression, and transaction are ruled out, if the patient has developed a nerve injury, it could be because of the post-surgical inflammation. And the diagnosis is based upon the nerve conduction studies, the electromyography, and the nerve biopsy. So what are the telltale signs of the post-surgical inflammatory neuropathy? Deficit will be specially distinct from the site of surgery, like a brachial plexopathy after a hip surgery. The deficit which is temporarily distinct from the site of surgery, like ulnar neuropathy which occurs days after an OPD procedure. And there could be progression of weakness or pain post-operatively, no clinical improvement within first month. Or the patient could have a severe neuropathic pain or patchy involvement of muscles on electromyography. And the treatment for such type of neuropathy is IV steroids, and they could require it for a prolonged duration of time. Now coming to, as we all know that prevention is better than cure, we need to modify our anesthetic technique and we need to change ourselves. So we need to know what are the potentially modifiable anesthesia risk factors. So we have various nerve localization techniques. We need to time the block in relation to general anesthesia, the needling technique, the needle design, the injection pressure, choice of local anesthetic, and the use of adjuncts. So what are the various nerve localization methods we know? So before, when we were using paresthesia technique, the chances of to detect needle to nerve contact was only 38%. With the help of peripheral nerve stimulator, there is 75% chance to detect needle to nerve contact. And this has been confirmed by the ultrasound that if the motor response is present at 0.2 milliampere current, it reliably indicates intraneural needle location. So coming to the injection pressure monitoring, as I already described, that if the needle is intrafascicular, the injection pressure will be high, and if the needle is extrafascicular, the injection pressure would be low. And this cutoff has been revised by various studies about at 15 psi. So if the injection pressure is more than 15, there could be possibility of intrafascicular needle tip placement. And this study by Jeff Gadsden in 2014 uh, have compared the paresthesia technique with the electrical motor response and the opening pressure. And here we can see that the needle to nerve contact, if the injection pressure is more than 15 psi, is being detected in more than 95% of the patients. Coming to another device called as Nerve Guard, it automatically blocks the injection when the injection pressure exceeds the limit value. And there is no need of monitoring or no visual control. So the ultrasound has revolutionized the regional anesthesia as well as the perioperative medicine. So definitely it reduces the chances of peripheral nerve injury. However, the multiple studies have done and they have claimed that none of the techniques are superior to one another in terms of risk reduction of the peripheral nerve injury. So this is the article from the ASRA, which states that the incidence of peripheral nerve injury has remained stable irrespective of the use of ultrasound. The frequency of long-term neurological symptoms have been equivalent irrespective of whether you use an ultrasound or a peripheral nerve stimulator, and the reported rate of long-term injury is similar. So most of the studies now recommend to use all the three modalities together so as to reduce the rate of nerve injury. So what are the strategies for better needle tip visualization when we are using ultrasound? There are echogenic needles which are available, which have depth markings and nanoline coating, which leads to more refraction of the ultrasound waves and which the needles can be seen better. The needle beam angulation, the angle at which the needle shaft and the ultrasound beam interact, the optimal angle have been described around 55 degrees during in-plane approach. And with the help of hydrolocation, the needle tip can be visualized more efficiently. This is a advanced technology which has come now, the electronic needle tracking. So in this study, what they saw that in the in this needle, there is extra sensor which is made up of a piezoelectric crystal is present at the ultrasound tip. And as the needle approaches to the nerve, and if it is under the ultrasound beam, the ultrasound image displays the green symbol on the screen. So this is known as the needle tip tracking technology. It is still under research. And here we can see that in image A, the needle is nicely seen. And so there is a green circle surrounding the needle tip. However, it can also detect the needle tip even if it is not under the ultrasound beam. So depending upon the distance from the nerve, it can show whether it's in the dangerous zone like the red circle or the blue circle. Now coming to the block timing, there is again a lot of controversy whether we need to give a block in patients who are awake, sedated, or under anesthesia. However, the evidence is still insufficient. So irrespective of taking all the measures, if the damage has happened and the patient presents to you with a nerve injury, so what are the steps we need to take? So we need to identify it promptly, diagnose it accurately with the help of nerve conduction studies, electromyography, and the neurological referral. Do proper documentation regarding the type of injury the patient has suffered, and effective communication with the patient. Also, we need to follow up the patient timely and guide him for the proper management of the nerve. So the systematic approach to peripheral nerve injury, there is a shared approach which has been described by Dr. Sunavne et al. In 2023. Refers to symptoms categorization, history, examination, diagnosis, and management. So we need to identify whether the patient is having mild pain or severe pain. We need to take proper history regarding the origin, duration, and progress of the symptoms, the patient profile, surgical related history, and the anesthesia related history, depending upon the type of surgery, position given during the surgery, the type of block, the type of needle used. We need to examine the patient, a detailed examination of the vascular structures and the neurological examination, as well as a local examination to identify the risk factors causing external compression or internal compression. And if we need to diagnose the type of nerve injury, there are various modalities like within 24 hours, we can do a magnetic resonance neurography, which will detect the nerve lesions, or we can do a high resolution ultrasound. Within 1 to 2 days, nerve conduction studies helps us to detect the nerve lesions. However, for electromyography, we need to wait for at least 2 to 4 weeks. And depending upon the type of injury, the management changes. In most of the cases where the neuropraxia has developed, the reassurance is needed with multimodal analgesics and regular follow-up. However, if the patient has developed axonotmesis or neurotmesis, we need to involve multidisciplinary team with the help of neurosurgery, physiotherapy, occupational therapy, and psychiatry. This is another algorithm which has been described by the RAUK, and similar to the shared approach, they have commented upon the modalities of the nerve injury and how to approach to the patient. Last, this is the article about the peripheral nerve injury arising in anesthesia practice. It states that any nerve injury which occurs during the perioperative period states that any injury during anesthesia is not equivalent to injury caused by anesthesia or the anesthesiologist. The severe perioperative nerve injuries are often associated with surgical incision, retraction rather than the anesthetic technique or patient positioning. So to conclude, the strategies and methods to reduce nerve injury, always try to do it in an awake patient if possible. Use a triple monitoring. Use short bevel echogenic needle. Take a tangential approach. Avoid intraneural injection. Avoid paresthesia and do your block with minimal local concentration. Thank you. And patient safety is a priority always. Thank you so much.
Thank you, Dr. Viral.
Thank you.
When should you refer the patient to neurologist? Meaning, when do you think you should refer a patient to neurologist?
So, madam, at the outset, first thing is before giving any block, I would rule out pre-existing neuropathy. I would first discuss with the surgeon whether there is a possibility of nerve injury during the surgery. I would try to optimize my techniques for giving the block. Irrespective of this, if the patient has developed a nerve injury. So now if the patient is coming to me, say the block duration has prolonged more than 48 hours, which creates alarm. So first evaluation, I'll go myself. We need to check whether the patient has got a sensory or a motor block. Now, depending upon the surgical factors and the anesthesia technique, we can determine whether this could be severe or not. So we immediately we can wait for at least 72 hours. But if there is persistent motor deficit, which is not reducing, then we need to refer the patient for nerve conduction study in the initial 1 to 2 days. And that can help us to identify uh, that whether any type of axonal demyelination injury has occurred or not. But if the motor motor complaints are still present, I would definitely like to involve a neurologist, and further evaluation is needed. Also, we need to target the injury, or we need to capture the nerve injury as early as possible. We have got a high resolution ultrasound nowadays, which can definitely detect if the patient has got a neurotmesis or a axonotmesis, and that can help us for further management.
So it's better to involve the neurologist early, I
As
think, for
early as
medical
possible.
legal reasons. It may be surgical cause or anesthesia cause. Most of the time, as you rightly said, it is not anesthesia cause. There may be various reasons why there may be delay in the motor activity to come back, but it's good to involve a neurologist from medical legal point of view also.
Correct.
In addition to reassurance, can you start anything for the patient or?
Ma'am, we can give steroids because many of times there could be just local edema surrounding the nerve which can settle with the steroids. So that is the initial thing which we can give along with reassurance, and also for the physiotherapy, so that the muscle power and tone is maintained.
But should we start steroids or takes?
We can definitely take an opinion, ma'am, but empirically also we can start it.
May I ask a question, please? Dr.
Yes,
Mayank
sir.
this side.
Sure.
Yes, sir. Yes, sir.
Yeah, nice, very nice presentation, Doctor. Just a small doubt that what is there any noted incidence of herpes zoster, kind of a dermatomal spread if there is a nerve injury associated?
Sorry, sir. I couldn't hear your question, sir.
Is there any incidence of herpes zoster in a dermatomal distribution post kind of a nerve injury, or there is an edema if that particular thing has settled, but after some time, is there any reported incidence of herpes zoster in that particular dermatomal distribution or something?
Sir, if I have myself not come across that, but there could be a possibility that the patient might have a subclinical herpes, and if we have given a nerve block, but I don't think they are clinically related.
So have you come across a case like that, or why you asked this question?
Actually, why I'm asking this particular question is that I have read in the textbook of Collins Regional Anesthesia. Collins Regional Anesthesia about an incidence of herpes zoster because of the inherent dorsal root ganglion herpes lying subclinically in immunocompromised patient. Specifically, if it has been given a block for AKT, the acute, the chronic kidney disease patient for AVF. Immunocompromised patients.
Okay, sir.
Okay. I think we go to the next topic and then we'll take the questions at the end.
So am I the host? Can I start sharing?
Yes. Naina, please introduce Shruti.
Yes, madam. Our last topic for today's webinar is by Dr. Shruti Patil. Topic is regional anesthesia in patients receiving anticoagulants and antiplatelets. Dr. Shruti Patil is a additional associate professor in Department of Anesthesiology at LTM Medical College and Municipal Hospital, Mumbai. Over to Dr. Shruti.
Yeah. Good evening, everyone. And thank you, seniors and esteemed members of RSACP. And thank you, Deepa ma'am, for this opportunity. I'll start. So my talk is based on 4 articles, 2 of which are recent guidelines of regional anesthesia in patients on antithrombotics. So these guidelines are confined to adult surgical patients 16 years or older and obstetric patients. We are going to focus on anesthetic and analgesic blocks and not on diagnostic interventions such as CSF drainage or pain interventions. So these have 1C evidence because not enough RCTs are available. So what regional anesthesia are we talking about? We are talking about peripheral nerve blocks and central neuraxial blocks. So why is the time interval between the last dose of antithrombotics and regional anesthesia intervention important? What we don't want is formation of a spinal epidural hematoma or a peripheral hematoma leading to devastating neurological sequelae. So now we have broadly categorized our regional blocks into 2 categories. One is deep nerve blocks or neuraxial blocks and superficial nerve blocks. The deep nerve blocks or neuraxial blocks, after the block, if a hematoma is formed, it is difficult to compress that hematoma. We need a surgical intervention.
Excuse me, Shruti, your slides are not seen. Are you seeing your slide?
Yes.
We are just seeing your, I'm not seeing your slides.
Yeah.
Okay.
Yes.
Yeah, yes, thank you.
Yeah?
Yeah.
Yes.
Okay. So we have divided our regional blocks into 2 categories, that is deep nerve blocks or neuraxial blocks and superficial nerve blocks. Now the deep nerve blocks and neuraxial blocks, if a hematoma is formed, it is very difficult to compress that hematoma. If you have to compress that or decompress that, you need a surgical intervention, and hence strict adherence to the antithrombotic guidelines is essential. As far as superficial nerve blocks are concerned, if a hematoma is formed, we can compress it, and hence it's not mandatory to stop the antithrombotic drugs before the intervention. So the deep nerve blocks are stellate ganglion block, deep cervical plexus, cervical paravertebral, infraclavicular, epidural, that is thoracic epidural and thoracic paravertebral, then lumbar plexus, psoas compartment block, lumbar sympathectomy, lumbar paravertebral, QL block, fascia transversalis, sacral plexus, then Peng block, and the sciatic nerve block, proximal approaches, that is about the subgluteal level, and most importantly, spinal and epidural. Sorry, I'm not able to change. I think
it will change. Just
frozen.
tap on your pad.
Yeah, I am. I want to escape also, it's not going.
Even I struggled a little, and it after some time it went.
Oh God.
You can go back to the sorter view and then try.
Okay.
Yeah.
Trying to escape, but it's not. I'll share again.
It's not? Yeah.
I'll share again.
Yes. Yes. Do
Stop
that.
sharing and then
And I
share.
will share again.
Yes.
Yes.
Yes. Yeah.
Is it seen?
Yeah, it is seen now. Now come to full screen view.
Yes. Yeah. It is seen.
Yeah.
Yeah, come to full screen
Now
view.
full screen.
Yeah, this is full screen view.
No, this is not full screen.
No.
Yeah, is it?
No.
No, it's not moving.
Ma'am, on
Still the
the
same.
right
Well,
lower bottom corner, there is a button, the
Full screen view.
adjacent to
Huh?
the yellow button. Please press that. Yes, this one.
Yeah. Is this okay?
No, it's not yet.
Shruti, it's not this thing.
Okay.
try pressing the same button which you pressed just now.
No, you're not pressing that. Press the
Yes,
last.
yes, it is. It is now.
Yes.
Yeah.
Now it is.
Okay.
Please go ahead, ma'am.
Yeah. So what are the important interventions that we are talking about? Needle insertion, needle blockade, then catheter insertion and catheter removal. So similar time intervals have to be respected for insertion of the needle with or without a catheter and for removal of a catheter at neuraxial and deep nerve block levels. Now coming to the anticoagulant drugs and their mechanisms of action. So unfractionated heparin, it acts by inhibiting factors 2A and 10A. Then low molecular weight heparin selectively inhibits factor 10A. Fondaparinum, which is again a parenteral indirect 10A inhibitor. Then rivaroxaban, apixaban, edoxaban, which is a direct 10A inhibitor, can be given orally. Then coming to dabigatran, which is again an oral anticoagulant, which acts directly by inhibiting thrombin. Then coumadin derivatives, which are vitamin K antagonists, affects the vitamin K metabolism in the liver, thus decreasing the production of clotting factors 2, 7, 9, and 10. So this is the pictorial representation of our intrinsic and the extrinsic pathway and the targets for our anticoagulant drugs. So coming to low molecular weight heparin and unfractionated heparin. Now, the low dose low molecular weight heparin means you're giving less than 50 international units per kg per day, or enoxaparin less than 40 milligrams per day. So the time from the last drug intake to the intervention should be 12 hours. If your creatinine clearance is less than 30 mL per minute, then you have to stop the drug for at least 24 hours or half the dose. The target lab values here, you need not test if you're giving a low dose, and after the procedure, you can restart the drug at 4 hours. If you're giving a high dose, then you have to stop for 24 hours and you have to test your anti-10A assay levels, which is less than 0.1 international units per ml per minute. Now, with the catheter in C2, you cannot give a high dose. You have to give an interim low dose, and only after removal of the catheter, you can give your next high dose. Now coming to unfractionated heparin, that means less than 200 international units per kg per day subcutaneously, or less than 100 international units per kg per day IV. So this has to be stopped for 4 hours before you do your intervention. And yeah, so we are giving, all of us are giving high dose, which is 5,000 international units QID. So for that, we have to wait for 6 hours if you're giving IV and 12 hours if subcutaneously. And then you have to also monitor your APTT, or the anti-10A assay has to be done, or an ACT. Suppose you have given a low dose of, suppose you have an epidural catheter in C2 and suddenly you have to go for some vascular surgery if there is a vascular intervention required urgently. So with the catheter in C2, you are allowed to give a low dose of heparin, unfractionated heparin, within an hour. But you should avoid going for full heparinization. You should delay it for the next 6 to 12 hours. Okay. So if you are giving a high dose of heparin with a catheter in C2, you have to shift to a low dose of unfractionated heparin and then give the high dose after removal of the catheter. So now coming to the vitamin K antagonists, which are most commonly used, is warfarin. So that has to be stopped for 5 days. You have to target an INR to levels less than 1.4. And with the catheter in C2, you cannot give the vitamin K antagonist. You have to remove the catheter and then give it. But still, if you need to give some antithrombotic agent, then you can give a low dose of low molecular weight heparin whilst the catheter is in C2 and restart the vitamin K antagonist 24 hours later. So now categorization of the doses of directly acting oral anticoagulants. So what is regarded as low dose is venous thromboprophylaxis for major orthopedic surgeries, then for acute coronary syndrome and prevention of sequelae of and arthrothrombotic events in a patient of peripheral vascular disease. So what is low dose for rivaroxaban is less than 10 milligrams daily. For apixaban, it is less than 5 milligrams daily, and dabigatran, it is less than 220 milligrams daily. So Coming to our direct NA antagonists, if you are giving low dose, rivaroxaban in edoxaban has to be stopped for 24 hours. And if your creatinine clearance is less than 30, then you have to stop for 30 hours. Apixaban, you have to stop for 36 hours. Now, with a catheter in C2, you cannot give this. So after removal of the catheter, you can restart the low dose 6 hours later. If you're giving a high dose of these drugs, then you have to wait until the target lab values, which are drug levels less than 30 nanograms per ml, or alternatively, you can do an anti-10A assay, which is with levels less than 0.1 international units per ml, or this would generally take about 72 hours. So you cannot give this drug with the catheter in C2. You can give an interim low dose of low molecular weight heparin if required, and then restart after 24 hours. So coming to dabigatran, low dose, if given, you have to wait for 48 hours. And after the catheter is removed, you can restart at 6 hours. If high doses are given, then usually you have to target the lab values, that is your direct thrombin inhibitor levels, that is drug levels less than 30 nanograms per ml. Alternatively, you can do a thrombin time or wait. This generally takes more than 72 hours to normalize. And with the catheter in C2, you cannot give this drug. In the meanwhile, you can give an interim low dose of low molecular weight heparin and restart dabigatran high dose after 24 hours. So coming to fondaparinol, which is an indirect 10A inhibitor, and this you're giving subcutaneously. If you're giving a low dose, it is less than 2.5 milligrams per day, then you have to stop for 36 hours. And preferably after catheter removal, you can restart it 6 to 12 hours later. So if you have a creatinine clearance which is less than 50 ml per minute, then you need further dose reduction or wait for 72 hours. If you're giving high dose, then it is not recommended to perform a central neuraxial block. But if it is unavoidable, then wait for the target lab values, which is the anti-10A assay less than 0.1 international units per ml per minute. So this would take generally more than 4 days. And similarly, after the intervention is performed, you have to again do your anti-10A assay, and after achieving the target, you can restart the drug. So this usually takes 4 days. Now coming to the antiplatelets. So the different steps are inhibited by the different antiplatelet drugs. So the platelet activation and aggregation cascade. Activation requires thrombin, collagen, ADP, thromboxane, A2. So we have our acetyl salicylic acid or aspirin, which inhibits the synthesis of thromboxane A2. Then we have the P2Y12 receptor inhibitors of ADP, which are clopidogrel, prasugrel, ticlopidine, ticagrelor, and cangrelor. And then we have the inhibitors of the GP2B3A inhibitors, which are abciximab, iftafibatoid, and tirofiban. This receptor is responsible for the platelet aggregation to take place. So now coming to our antiplatelets, aspirin, low dose is when it is administered in doses less than 200 milligrams per day. So you need not stop this dose of aspirin, and you can safely perform your central neuraxial block or deep block. So if you're giving it high doses, then you need to stop it for 3 to 7 days and also monitor your platelet functions by doing a bleeding time or viscoelastometry or platelet aggregometry or flow cytometry. Thereafter, restart aspirin after the procedure after 6 hours. So coming to the P2Y12 receptor inhibitors, so you have to wait for 5 days after ticagrelor, 5 to 7 days after clopidogrel, 7 days for prasugrel, and also monitor the platelet function. Now, you can restart these agents only after withdrawal of the catheter. So after catheter withdrawal, you can give clopidogrel 75 mg immediately, prasugrel and ticagrelor after 24 hours, and after 2 days, you can give a high dose, that is 300 milligrams of clopidogrel. So if you're giving an low dose aspirin with another antithrombotic, then the time interval of the specific antithrombotic has to be respected. Now coming to thrombolytics and fibrinolytics. Thrombolytics and fibrinolytics like streptokinase and alteplase, usually it is not recommended to perform a central neuraxial block after administering them, but if it is an emergency, minimum 48 hours you have to stop. And also all your lab values have to be within normal range and includes fibrinogen levels. Now, if you have to again give the drug after your central neuraxial block catheter removal, then you have to wait at least for 10 days. Now, there are many other anticoagulants which have not been discussed in the ESRA 22 guidelines because they are less used. If at all they are used for patients who are critically ill who will not require central neuraxial block. But in India, we are still using some of them. So coming to the parenteral thrombin inhibitors, argobatran, it is recommended not to perform neuraxial techniques with this parenteral thrombin inhibitors being given to the patient. Then GP2B3A inhibitors, iftifibatide and tirofiban, you have to wait for 8 hours. Apiximab for 24 to 48 hours. And it is recommended that you do not restart the drug for 4 to 6 weeks after the intervention. Now coming to the phosphodiesterase inhibitor, xylostazol, which is very commonly used, you have to stop for 42 hours. And then you can restart the drug after catheter removal, that is after 6 hours. Now, if you have a combination of antithrombotics, then the therapy-free time interval should be that of the drug with the longest interval. No need to increase the time intervals longer than that of the drug with the longest time interval. Then we have several antidotes or reversal agents which are available. And as far as vitamin K antagonist or warfarin is concerned, you can antagonize its action with prothrombin complex concentrate and vitamin K, and you can perform a central neuraxial block or a deep nerve block if it is an emergency, weighing the risk-benefit ratio. Dabigatran is antagonized by idarubicimab, so you can perform a central neuraxial block or a deep nerve block after giving this drug in an emergency situation, again weighing the risk-benefit ratio. Unfractionated heparin, you can give protamine and you can perform the above block, but avoid protamine overdose because protamine itself is a anticoagulant. So there are antidotes for other drugs also, but there are no recommendations for performing a central neuraxial block when those are given. So in obstetric patients, same recommendations are used as for the non-pregnant population, but in selected parturients at high risk of a thrombotic event and requiring an unplanned or an urgent intervention for maternal or fetal indication, and if the risk of GA is very high as compared to the central neuraxial block, after multidisciplinary discussion and individual risk-benefit analysis, a deviation from the current ESRA guidelines may be considered. So there are certain special situations you have to give an antiplatelet or anticoagulant with the neuraxial or central or deep nerve catheter in situ. Then you'll have to do continuous lab drug monitoring and neurological monitoring. With loading doses of aspirin and clopidogrel, if they have to be given with the neuraxial catheter in situ, then what you can do is remove the catheter immediately because the clopidogrel takes about 4 hours for its peak effect. In cases you have to give a combined antiplatelet and anticoagulant drug, and a neuraxial catheter could be removed after reducing the anticoagulant dose or replacing the antiplatelet drug with a short-acting one, which is tirofiban, iftifibatide, or cangrelor. So there are a few other recommendations given. That is, peribulbar anesthesia should not be given if you are giving the patient clopidogrel. Better to give a subtenance block or a topical block. If you are giving a high antithrombotic therapy, high dose antithrombotic therapy, better to delay for 48 to 72 hours restarting the drug, because in case you have a high bleeding risk, and also if you're not satisfied with the surgical hemostasis. Then Single puncture spinal anesthesia is always preferred over epidural anesthesia. Thromboprophylaxis should be delayed if you have had a bloody tap during spinal. Ultrasound is always preferred because it reduces the incidence of vascular puncture. And lowest bleeding techniques by an experienced person or experienced operator is always preferred. Avoid combinations of antithrombotic drugs with NSAIDs, tricyclic antidepressants perioperatively. They may exacerbate the bleeding. Now, if at all there is a high suspicion of hematoma following a deep nerve block or a central neuraxial block, then you need to monitor the patient every 30 minutes. Ideally, a trained person should do it for a minimum of 24 hours up to 48 hours. And what are the red flags? If you are having a new onset of neurological deficit, then this is pathognomonic. If the pain is just out of proportion, the back pain, and your block has got prolonged far too much, then you should order for an urgent MRI, and you get best results if you can perform surgical decompression within 6 hours. Thank you.
Thank you, Dr. Shruti. Any questions? The chat box, anybody?
I think the questions in the chat box are answered by the
Yeah,
respective
they have already been
speakers.
answered. So the in addition.
Yes. Yeah.
Good evening, madam. Abhay here from Dubai.
Hello.
Good evening, Abhay.
Hello, sir.
Yeah, there is one, actually, Dr. Shruti has given a nice talk about this anticoagulants. One more thing about this anticoagulants, we need to discuss with the surgeons also.
Yeah.
Because recently we have come across one case, we have placed an epidural catheter for laparotomy. And after laparotomy, means the surgeon didn't know that, means he knew that patient has epidural, but he gave fondaparinux.
Oh.
So as per ASRA guidelines, we cannot place the catheter and we cannot remove it. So it's very essential that about this anticoagulant, the surgeon should also be aware when we are placing any central neuraxial catheters. So that's the additional point we have to be kept in mind always.
So we should also look into this thing, because even we had a similar thing where LMWH was administered to the patient. We're planning. So, as you said, communication is important in this. And the sisters, the surgeon's orders. So it is, immediately followed.
Yeah, there is a recent surge in use of these oral anticoagulants, and we cannot make out from the post-op orders, what exactly that drug is. We really need to send our residents for rounds to have a look at even their orders, what they're writing. If we are going to look at our epidural catheter or give a top-up, our resident should also go and see and check the orders.
Yeah,
Because
very
many
good
of those-
point, Shruti. Yeah, sometimes the orthopedic surgeon will just write Xeralto
Yes.
and they don't know it is
Absolutely.
Rivaroxaban. So
Yeah.
type of confusion can occur. It's important. And as you said, communication is also important. Abba, you had made some comment on neurological documentation. What
Yeah.
exactly are meaning by that?
Yeah, actually, we should always document this regional anesthesia block. Means when we are planning for any regional anesthesia, right from pre-op, we should start that patient sensory. Was there any sensory or motor deficit right from pre-op? So that if there is any deficit in the post-op, we can compare with the pre-op and post-op. Most important thing. Plus the surgery, specifically humerus fixation surgeries, when we are giving intrascalene block, there are incidences happen that the surgeon has injured this nerve and it came to anesthesia. So there's documentation as well as what the surgeons are doing during the operation. We should be totally aware.
Yes.
Yes, many times it is because of tourniquet.
Yeah.
Yeah, so double crush. I think Viral has included tourniquet in that. Viral, would you like to comment more on the double crush? Because that is what we face many times.
Yeah. So, ma'am, as I already mentioned about the double crush phenomenon, so it mentions that whenever any patient has any form of a nerve injury, the preoperative, the single trauma to the nerve has already happened. So double crush states that in such patients, if you give a nerve block or if any second insult is being done, there is a probability that the neurological deficit may increase. And the mechanism which they have described is because of the axonal flow of the nutrients from the cell to the periphery, there is restriction or there is damage to that flow, which can progress the neurological deficit. But there have been case reports which are questioning that phenomenon. So still we don't have a proper evidence as such. That's what has been described in many studies. But yes, we do have many case reports which say, or studies which say that we need to avoid nerve block in any patient who has got any form of preoperative symptoms like a sensory deficit or a motor deficit.
Yes. Naina, any other question? I can't see any questions.
No, there are no questions, madam. One suggestion by Dr. Arpita, in the immediate post-operative period, at least day 1, mechanical thromboprophylaxis is safer and also can monitor efficiency of surgical hemostasis.
Yeah, actually,
yeah.
there are 2024 ESRA guidelines which have given recommendation within how much time after surgery, which surgery, what prophylaxis should be started. So you can go through them. So depending upon the surgery. So of course, mechanical thromboprophylaxis has to be given.
One question to Dr. Viral Parekh.
Yes, sir.
Are you using this pressure injection monitor regularly?
Sir, we don't have it regularly, but if it's available, then we do use it. Not for all the blocks, but if it's available, we do use it. But peripheral nerve stimulator and ultrasound we are using for all the blocks.
But I meant to say, does it have any additional benefit of using it?
Definitely.
Sir, it definitely adds to the safety.
Safety and medical legal purpose. I agree
Yeah.
to it. Yeah.
Because there have been patients who come who are well educated, they have read and they ask, have we used all the modalities? And if we say yes, we have used 1, 2, 3, everything, whatever is available in our institute or at our disposal, then we are medico-legally safe in that aspect.
Actually, I recently read somewhere that the patient had some problem and the relative came and asked this question, whether all
Yes.
three, which webinar where I read
Yes,
it, but
yes.
May I comment on this?
Yes, Devangi.
So basically, I have been using, I had used there are 2 nerve guards. One is the Bebron one. So that is a little tricky to use, but the compressed air injection technique is very easy to use. It's such a simple thing. You take a 10 cc syringe, fill it half with air, fill half with saline. And before injecting, you use that only for injection. And if it compresses, if you're using like there is 5 ml of air, 5 ml of saline, so you are supposed to compress the air only up to half. So more than half, if you're requiring to compress the air, that means there is a chance of an intravascular injection. This is a very simple, cost-effective technique which has been published also. It is the CAIT technique.
Yeah, by Bansui et al. There's a
Yeah.
paper by him itself.
It's a very good technique, and it's even in a low resource setting, we can use it.
So Devangi, for this you use a 10 cc syringe and every time you take only 5 cc of the local anesthetic
Yes.
and 5 cc of
Of
air.
air. Yeah. And when you inject,
Yeah.
your guideline should be, I don't have to push the plunger beyond 7.5. The
Okay.
air is up.
Hmm.
When you push the plunger,
Yeah.
while you're pushing the plunger, the eyes are on the USG screen and the hypoechoic saline should be seen.
Okay.
Now, when you're pressing the plunger and you're pressing it a lot and still no saline is seen on the screen, means you're requiring high pressure. So you're not supposed to go beyond 7.5.
Yeah, but
when you inject it,
Saline is
on
down, air is up.
yeah, but practically, are you doing this?
No,
It's a good
not
thing.
regularly. We
Yeah.
had done it for a project and a research paper, but honestly, we are not doing it regularly.
Yeah. So practically, do we do it?
So I think what I recommend
And,
is something like interscalene block where connective tissue is less, we should
Yes.
use it. But a peripheral block where connective tissue is more, we can avoid it.
Yeah. And
Uh,
look, using that small device, it's just that the cost goes up by another 200 rupees. Yeah, but it does
Exactly.
make a difference in government sector.
Yeah, in government
But-
setup, even the small
Yeah.
CAIT technique, and it is tested. There has been case reports, there has been articles where they've compared the CAIT technique with the nerve guard, and
Right.
it has it is good enough. Nerve guard is expensive.
Yeah. It's about 200 rupees. So,
Yeah.
There is a question for, I think, Devangi.
Hmm.
Do you use LOR syringe of epidural kit for this?
No. Because it is of no use. We'll have to use a normal syringe, a normal plastic syringe, not the LOR syringe.
Question from Dr. Deepa. Any thoughts on video recording while giving blocks for medico-legal
So,
purposes?
ma'am, I would like to answer this. Means video recording per se, if we have ultrasound and if we are giving ultrasound guided blocks, so certain machines do have the option of saving the clips, and we are doing it for a lot of patients. So, if that also depends upon the memory of the machine and how easily you are able to retrieve. So, if you have that facility, you can definitely record the ultrasound block videos or pictures for safety.
I think most of the questions have been answered, or all of the questions have been answered from the chat box. So if there are no more questions, Madam, can we conclude now?
yeah, I think all three lectures were excellent, I should
Yes.
say. They were really excellent lectures. I hope the delegates have all enjoyed all the lectures. And Naina, you can say the vote of thanks.
Thank you, Madam.
Sorry to interrupt you, ma'am.
Yes.
I would like to say something.
Yeah.
It was a wonderful session. All the three lectures were so wonderful. We have with us Dr. Anju Garewal, ma'am, President-elect RSACP. Madam, please, can you share your few words, ma'am?
Yeah,
Dr.
a
Anju
very
Garewal,
good.
ma'am, please.
Yeah, a very good
Please
evening.
welcome,
Thank you.
ma'am.
Thank you so much, Dr. Vishal, and a very good evening to all respected members, faculty here, and the GC members. It is an honor to be, being here to invite you all for the 33rd Annual National Conference of the Research Society of Anesthesiology, which is being held at AIIMS Batenda from 28th to 30th March. So it'll be a pleasure to have you all. I will be sharing the brochure also in the groups, and will be sending invites and would recommend and exhort all of you to join us. We will be doing around 11 workshops, and so we are almost in the process of curating our program, and soon we'll be sending specific invites as well. But however, the highlights of the program are the 11 workshops, the 11 award sessions for abstracts for students and postgraduates as well as faculty. We're also introducing a 1 minute, just a minute session, which is a competitive session for all entries. And so I hope together we'll be able to make it a very good academic meeting at AIIMS Batenda. Thank you so much for the opportunity, Dr. Vishal. Over to you.
And to add on to Dr. Anju Grewal, the workshops are on Sunday.
Yeah.
Yeah, so those postgraduates who find it difficult because of leave issues, so if they are the post-conference workshops, the 2-day conference will be on Friday and Saturday, and and Madam has mentioned different award sessions, plus keynote addresses, pro con debates, 6-minute shots, right? Where
Yes.
clinical pearls are discussed, and ROM session, RSAP 1-minute session. All of these are there to make it a very, very interactive program. So you are cordially invited to enjoy the hospitality of Punjab, which is well known, and with the Royal Punjabi food also. and a visit to nearby Golden Temple.
Definitely.
You are all cordially invited, and I thoroughly enjoyed listening to all the speakers, and good work done by RSACP Mumbai team, and heartiest congratulations to each and everyone.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much, sir.
So,
Also, I would like to mention that next week we'll be having another webinar on artificial intelligence and chat GPT. Please do join us. We'll soon be sharing the link. Thank you very much.
This will be hosted by RSAP Uttarakhand branch and RSAP Dehradun city branch.
Over to you,
So
ma'am,
we-
please.
yeah, thank you. With this, we now come to the last part of this webinar, and I, Dr. Naina Dalvi, Secretary of RSACP Mumbai branch, would like to propose a vote of thanks. I am greatly thankful to our patron, Dr. Tejpal sir, for being with us throughout the whole webinar. And we sincerely thank RSACP President, Dr. Naveen Malhotra, Secretary Dr. Vishal Singla for all their support to us in conducting this first webinar of our new committee. Our sincere thanks to all the ex-office bearers and the future office bearers of RSACP National. And I would like to thank both the moderators, Dr. Deepa Kane and Dr. Sona Dave, for their expert opinion and for conducting this webinar smoothly. Thanks to all our speakers who really shared their knowledge about the update of regional anesthesia, and it was truly wonderful. And thanks to all the attendees who were there in great number. We almost had a full session. So thank you very much to all of you, and good night.
Thank you and good night.
Thank you.
Good night, ma'am. Thank you very much and good night.
Thank you.